Examination of the shoulder. The aim of this video is to introduce students to the examination of the shoulder and to introduce students to reporting their examination findings. The objectives are to demonstrate the ability to examine the normal shoulder, to describe the major muscle groups in the shoulder, and to demonstrate the ability to perform tests of muscle power and range of motion in the shoulder. Introduce yourself to the patient and explain the reason for examination. Expose both shoulders by asking the patient to remove his or her top. Be mindful of maintaining the patient's modesty. Inspection should be performed from the front, side, and back of the patient. From the front, compare the attitude or position of both shoulders and note the presence of any deformities. Also inspect for any swellings, scars, and color changes. These are the important bony landmarks around the shoulder. Inspect for any muscle wasting over the trapezius, deltoid, pectoralis, and biceps muscles. From the side, note any postural changes or deformities, and from the back, look for muscle wasting of the supraspinatus and infraspinatus muscles, and the position of both scapula should be compared for any abnormalities. You should also notice any swellings, scars, or skin color changes. Before you initiate palpation, always ask the patient to point out any particular areas of pain. Inform the patient of your intention to palpate the shoulder joint and remind them to let you know if any area is painful during your examination. Palpation of the shoulders can be performed simultaneously or individually. As you are palpating the bony prominences and joints, you are trying to discover the presence of any tenderness, deformities, swellings, or fractures. Begin with feeling the temperature of the shoulder joint with the dorsum of your hand. Next, palpate the sternoclavicular joint and proceed along the entire length of the clavicle. At the lateral end of the clavicle is the acromioclavicular joint, and lateral to that is the acromion. Medial to the humeral head is a bony prominence, which is the coracoid process, to which the short tendon of the biceps brachii is attached. Palpate the humeral head, proximal humerus, and greater tuberosity of the humerus. Externally rotate the humerus as you are palpating the head to palpate the bicipital groove through which passes the long tendon of biceps brachii. From the posterior aspect, palpate along the spine, the medial border, inferior angle, and lateral border of the scapula. Assessment of movement should include both active and passive activities. It is best to demonstrate the movements to the patient when assessing active shoulder motion. With the patient standing, ask him to elevate a straight arm forward as far as possible. Normal flexion is approximately 180 degrees. Ask the patient to extend a straight arm backwards to determine extension range of motion, which is normally approximately 60 degrees. With his hands facing forwards, ask the patient to abduct both the shoulders. The initial 120 degrees of abduction is movement at the glenohumeral joint. Beyond 120 degrees, abduction is possible due to scapulothoracic movement. The normal range is 160 to 180 degrees. Adduction is tested by asking the patient to move the arm in front of the body and is about 50 degrees. Internal and external rotation are tested with the elbow flexed at 90 degrees and kept close to the body. Most of external rotation on adduction takes place at the glenohumeral joint. There will be some restriction of internal rotation by the trunk. It can be tested by asking the patient to place his hand behind the back and try to scratch the back as high up as possible with the thumb. Passive movements of both shoulders should be examined. The arms should be abducted, adducted, internal and externally rotated, flexed and extended. It is important to compare both the active and passive movements. The test for impingement is used to determine whether there is any rotator cuff impingement between the greater tuberosity and the subacromial arch. This occurs when there is damage to or inflammation of the rotator cuff. The patient has his shoulder abducted and elbow flexed to 90 degrees. The arm is then internally rotated. This pushes the supraspinatus tendon against the acromion and coracoacromial ligament. The apprehension test is used to assess where there is anterior instability of the shoulder joint. This often occurs after dislocation, where there has been significant damage to the joint capsule. This can be done standing, sitting, or with the patient lying in a supine position. The arm is abducted and elbow flexed to 90 degrees. The arm is then externally rotated at the shoulder. A positive test is when the patient becomes apprehensive or nervous and resists further movement. If direct manual pressure on the front of the shoulder relieves the apprehension, the so-called relocation sign, this is further evidence of anterior instability. End your examination by thanking the patient.